obstructive pericardial tamponade, or you should suspect massive pneumothorax. So my second question, since you have the provisional diagnosis, what of this is the best investigation tool to facilitate your diagnosis at this moment in our emergency department? You can select your answer in the QR as well. So I can see mostly are corrected. ECG was the right answer. Why we didn't choose chest X-ray and cardiac enzyme or bedside echo? Because we mostly in our emergency department in Malaysia, we have a ECG machine that it can help us to facilitate the diagnosis in the emergency department. Some of the hospital in district hospital, we don't have a chest X-ray or cardiac enzyme to help us to diagnose the patients lah, and also bedside echo. So I think ECG is the most appropriate investigation at this moment. Okay, so I will pass over to Dr. Azlan to continue my presentation. Welcome, Dr. Azlan.
Thank you, Cheang. Good morning, everybody. Just before we go to the ECG, I'm sure many of you will ask questions. Why do we suspect those differentials to begin with? And I'm pretty happy to see that many of you have chosen ACS, myocardial infarction, acute MI, acute heart failure in your list of answers. And the list is not exhaustive, but of course, in the setting of emergency department, you have very short span of spending with patients, and we have to be very focused on the history and the physical examination. So based on the evidence that we have at that point, the best, I agree with many of you, that we have to think of myocardial infarction until proven otherwise. But at the same time, there are other differentials that we have to think about because the management may differ. Even though, you probably argue why pericarditis, why dissection, it has to be in the differential because some of the pattern can be undifferentiated based on history and physical examination alone. So based on this, keep the differentials in mind. Then, because all of you have decided to do in the first instances of patient with MI, any of you know, this is not a quiz, you can shout out from the back if you know how long and how soon do you have to perform an ECG upon arrival to the ED? Any idea? Within 10 minutes. Excellent. So now within 10 minutes of arrival, this patient had the ECG done, and obviously he was sent to, maybe Dr. Cheang did not highlight that because of the condition, any of you have done emergency department posting, with that low BP, with the presentation of chest pain, you have red zone, yellow zone, and green zone. Where would you choose to send this patient to? Not loud enough. Where? Excellent. So all of you decide to send to the red zone. So we send the patient to the red zone and they perform the ECG, and this is the ECG. Now please pay attention to this ECG because this is not the usual ECG that you see every day. Right? So now, if you were to choose to focus on at this point, which lead do you like to focus on? There are many problems in the ECG, I should tell you. Let's start with the lead 2. Just to give an example, I put some reference there because many of you have just started your clinical postings and ECG is pretty alien to you and remain alien for many years, right? So let's do some exercise. Now I need you to work with me on this. If you give me the correct answer, then I will move on, okay? This is very basic, but I need to start with the basics. You learn about ECG in your medical student time. There are complexes and wave in ECG. P wave, QRS complexes, ST segment, T wave, and whatnot. Now, you look at the strip in lead 2. Now, I want you, I'm pointing out with arrows, and I want you to shout out the loudest you can. If I feel it's not loud enough, I will not proceed to the next level. Okay, tell me what am I pointing to? Again? Louder? Okay, it's a P wave. All right? So it can be deceiving. The reason I'm going to tell you why it's deceiving, because some of you may not answer P wave as your first answer, but that is actually the P wave. Therefore, what is that? Not loud enough. Louder. QRS complex. Based on reference, after your P, you should be seeing your QRS complex. But what about the QRS complex that is not normal? Inverted. Excellent. So you have a very good observation there. It's inverted. That's fine. So there's QRS complex there. Then what about that one? Not loud enough. The mix of answer there. Let's come to agreement. What am I showing there? ST and T. Excellent. So there's T wave, and of course you see some ST segment there. So you look at this wave, and you have this conventional QRS complex in your mind. Do they look the same? No. Okay. So they don't look the same. Then you ask yourself, okay, how do I count the rate? So the good thing is you have identified your QRS complex, then you can count the rate. So you've learned in medical school how you calculate your rate. R to R interval, very good. So you calculate the R to R interval, and you see the number of big boxes, and you found there's about 3.5 big boxes. And you divide with what's the rate now? Can you calculate for me and shout the answer? Some exercise. We have to do this because from the previous exam, I think we have to do some more training in ECG. So I take an effort to go slow with this. Excellent. So we have 85. So the rate is 85. You've got some very weird looking QRS complex, and the T wave is there but doesn't look normal as well. So now that's a lead to screen off to start off with. Then you look at the overall precordialates now. Let's focus on the precordialate because you're trying to diagnose MI. And then if you don't know how to diagnose MI, then this is the point where you start thinking, okay, yes, I'm suspecting MI. I have this ECG on my bedside. How do I use it? So I put the base reference on the left side there for you to, on the right side for you to think and compare. Now, we already identified the P wave, and you already identified the QRS complex. Now, what about the QRS complex? Shout out to me, normal or abnormal? Excellent. So consensus. So what is abnormal about it? Can you shout out to me, anyone? One big answer. Funny looking. Okay. Any more answer? I don't have the Mentimeter. Just if I can capture your word, that'll be good enough. W shape. Okay. Go on. So we all agree this is it a normal QRS complex? No. Okay. Is there R wave or is there R wave at all? Maybe you see some in V5, V6, but if you look at the V2, V5, V4, you see the first deflection is downward. And if you compare the size and the amplitude of your Q wave in the normal conventional ECG, is it small or is it big? Is it big? Yeah. So this is what we call the pathological Q wave, but the location is also not very normal. So pay attention to this abnormally looking Q wave. And what about it? Why is it called pathological? Because number one, the size and the duration is huge. So the duration of the QRS complex alone is more than one box. And then the location is not at the usual places where it's supposed to be in AVR, sometimes seen in V1 and lead 3. This one in the precordial lead. So if you see this in Q wave, very deep Q wave in your precordial lead, you should be very worried. Then the depth, if you see the definition of pathological Q, it should be more than 25% of the R wave. In this case, there's no R wave. Then it tells you a lot about, okay, one thing you have to learn, if you see a pathological Q, it tells you that the myocardial infarction has occurred, number one. Number two, it has involved what you call transmural infarction. It's not just the endocardium, it will involve the endocardium and the whole of the myocardium. So this is an abnormal looking Q wave, and it presents to you in more than 2 leads, what we call it contiguous lead, which reflect to a certain area in the heart. Now, this to give an example, this is what you expect to see in the R wave in a normal precordial leads. So capture this in mind, If you roll around in the ward, you see a precordial leads that look like this. R wave is smaller and getting taller and taller in V4, V5. That's what pretty normal to you, but not like this. Okay? So just capture the abnormal pattern and the normal pattern to begin with. Now back to this ECG. The next complex you see, or the wave that you see, you focus on, what's that? ST, good. So ST segment elevation. So all of us appreciate that there is ST segment elevation in this case. So there's Q wave, there's ST segment elevation. Both are actually worrying signs in ECGs. If you look at the amplitude, okay, you can go by the definition of universal definition, but I'm not going to dwell with it here because of the time constraint. But we all agree there is a degree of convex ST elevation in these leads. So we have a very well-formed Q. At the same time, we have ST segment elevation. So what does it mean to us now? Now we have a patient who is very unwell, chest pain, in BP is low, okay? And you do the ECG, you see a pathological Q wave involving V2 to V6. So a bit more advanced for a medical student, but for those who are beyond medical student, probably we should ask ourselves, when you see an ECG like that, well-formed Q that comes along with the established ST segment elevation, there are two possibilities, okay? It could be a patient who had LV aneurysm or a patient with ST segment elevation because of acute NMI, or it could be both. Now, given that the patient have got a chest pain for 1 week, what is not being highlighted in the history is that this uncle is actually working, he's a very a fit gentleman, okay? He was unwell, having chest pain for a week, but the doctor from KL went to visit him in Johor. Okay, he lived in Johor. He always went to his farm and all that, doing all these hardcore chores and all that, not a problem. But that 5 days, he was not very well. He didn't do the work that much. But the doctor was worried and brought him to the hospital, to KL. So all the way from Johor to KL and had this ECG after 5 days. So he could have been having the attack like 5 days earlier. So now, when we have that kind of pathological Q with ST segment elevation, we should be worried about these two. And the fact that he's got extensive ST elevation in V to the V6 with a poor R wave progression, what does it tell us? Then, you know, it supports further the extensiveness of the MI that we had. Earlier, we talked about the differential based on the cases. But when you see ST elevation in ECG for the medical student, you can start having this differential as well. Just to start off your thought, okay, if you see ST elevation in ECG, what could it be? So just remember ABC help. It could be acute MI, arterial dissection, Brugada, carditis, blah, 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 all this all the way to prismatic angina. But based on the symptom that we have, we are focusing on these two, right? So based on the calculation, then it favors more toward the acute ST elevation MI. Now, just to focus on the other aspect of the ECG that I want all of you to learn is that ECG comes in patterns in contiguity that reflects the region of the heart. Now, we saw ECG just now, there's changes in Q wave and also ST elevation involving V2 all the way to V6. Now, if you look at the potential vessels involved, this is where our cardiological lead come into the picture. But in ED, we need to identify this as well so that we can update our colleagues. What is our concern? So which lead or the coronary vessels is involved? Can you shout out to me? Based on the ECG pattern, which coronary vessel that most likely involved? Focus on V2, V3, V4, V5, V6. Those changes. Which coronary vessel could be involved? Shout louder. Right coronary artery. Anyone disagree? It states there, mentioned clearly, that we are suspecting potential involvement of LAD stands for left anterior descending. Okay, so now based on the ECG changes, we are worried, okay, potentially there's an involvement of LAD, but there's also some degree of ST elevation earlier in the 2-3 AVF, which could be involved in RCA, all right? Now, if you suspect LAD, just to have some understanding, if you do echo, this is the region where we focus on, especially in the ED setting. Sometimes we don't get to see or get the patient on angiogram while waiting for the patient to have angiogram or to establish diagnosis of MI. We have this bedside cardiac ultrasound to help us whether to seal the diagnosis. Okay, ECG shows this region. We do echo, we focus on this region. Now, this is the bedside echo, not the best example, but focus on the LAD area. Okay, again. So there's some lack of movement in the area where we're pointing out compared to the one below. I know the image, this is short axis view. And focus on the one in red. There's lack of movement on the area as well. And the point arrow in yellow is showing some lack of continuity in the muscle. I repeat again. The yellow is pointing to the lack of continuity of the muscles. And the red point is pointing towards hypokinetic area. That means the lack of movement in that region. Another area, another bedside cardiac ultrasound. Focus on the, there's a finger pointing as well. One of my registrars is pointing towards something. Can you appreciate the lack of continuity there? Right. Just spend a few more seconds and you'll see what is there. Do you see anything there? Okay, so I know it's moving, but there is some continuous flow to the other side as well. Right. So at this point, we're very concerned about this patient. We have activated our colleague in the STEMI network that the patient may, I mean, based on the ECG, we activated already, but then based on this finding, we're more concerned because we're suspecting something else is happening. And we did a chest x-ray, and you can see a diffuse reticular changes, which suggest patient have got acute pulmonary edema. There's fluid in the lungs as well. Okay, so at this point, this is our main concern. So patient have got an established extensive anterior MI with key 4, meaning patient have got a cardiogenic shock. The pumping is not great. And we saw there is a potential rupture in the septal area. So at this point, we are referring to our cardiology colleague as acute MI with potential ventricular septal rupture. We put him on oxygen because the low BP, we start him on supporting vessel pressure and no adrenaline and given the medication. Now the challenge is this. He's got a chest pain, can die anytime. He's already in cardiogenic shock, which favors higher risk of mortality. Now the worst part is this is the most feared complication that he has, which shown in the ECG, there is a potential ventricular septal rupture. So we get our cardiology colleague to come in because there's potential involvement of the cardiothoracic team as well. So now to take you through what happened next, I would like to invite our colleague, Dr. Haidir, to discuss what happened next to the patient before we talk about the condition. Thank you.
Assalamualaikum. Thank you, Dr. Azlan. He has done a very good job in explaining the ECG and has just made my presentation more difficult. I hope I'll do you guys justice in explaining what I'm going to talk about. So before we brought this patient to the cath lab, we got the chance to do a bit of investigations of seeing his heart in the sense of echocardiography. So, okay, so this is the echocardiography. For medical students, I put here the reference image, and I hope you can understand the reference image. This is the left atrium, LV stands for left ventricle, RV right ventricle, RA as right atrium. And this is the real image of our patient. So if you see color here, red means that the blood is flowing to the probe. The probe is over here. While blue means the blood is flowing away from the probe. Let me play the image. Okay, so there is a flow from the left ventricle to the right ventricle. And how do I know this? Can you see there's a mix of color here? Right? There's a mix of red and blue color here, which means the blood is mixed. And why is the blood mixed? Because there's a hole in the heart. And where is the hole in the heart? Correct. There's a hole here in the septal. Okay, let's move on. This is the apical 4-chamber view. All right, this is again the same apical 4-chamber view. Okay, so this is a bit clear image. Can you see there's a very harsh and turbulence of flow from the left ventricle to the right ventricle, because there's a hole here, and without the color you can see clearly there's a hole here, right? So there is a movement of blood from left to right. Okay. Okay, and this is another view we call a subxiphoid view, where you put the probe just beneath the subxiphoid so that you can get a view of the heart in another dimension. And let me play again. Okay. So again, you want to see the area of interest, which is the septal part, and see the blood flow from the left ventricle to the right ventricle, just to confirm your findings, whether there is any rupture or not lah. And from all these two views, we can confirm that there is ruptures, supporting by the color Doppler of the echo. Okay. So this is the findings of the echo. The ejection fraction is still okay at that time, and there is a hole in the ventricles which size about 1 to 1.5 centimeter, and there is a left to right shunt as expected from the ventricular septal rupture. So we brought this patient to coronary angiography, and it may be advanced for medical students and for my colleagues. I hope I do justice. This is the coronary angiography, and this is the reference image, LAD, LCX, and you can see LAD is not very clear view from here, but you can see some mid-segment blockage here. And while the left circumflex is also not as good flow as this reference image. Okay. You see some the image is very diseased. The left circumflex is very diseased. Next will be this image, where you can see there is at the mid segment of the LAD there is almost a total occlusion with some septal collaterals. Okay, and this is the RCA. RCA looks fine. It's just a mild disease throughout the RCA. Okay. So this is the finding. It's a severe to vessel disease with mid-LAD occlusion. And just a bit of the investigation for this patient. The hemoglobin looks stable, 9.9 to 10.8. Platelet is 280, 188, and white cell is 11 to 18, which is not very significant for this patient because we are not expecting infection. And the troponin, as expected, went very high from 5,000 to 48,000. Troponin for medical students are cardiac markers to show heart muscle injury. Okay, and this is to portray that the patient starts to having multi-organ failure. The multi-organ failure has sets in by the evidence of creatinine starts to climb up. ALT, AST is the liver markers. You also start to climb up. So the patient is on the verge of having multi-organ failure. Okay, so the progress in ICU after the angiogram, we were unable to proceed with the coronary angiogram, stent or balloons, because by RAC, when you have a patient with ventricular septal defect, surgical intervention is needed, meaning we have to call in CTC, cardiothoracic surgeon team, for definitive management, which is repair the ventricular septal rupture. However, because the patient is too unstable, even for transport, even for transfer, and because of the background of this patient, he has the underlying GIST tumor cancer. Family is also not keen for further intervention, and eventually patient succumb on the next day, unfortunately. Okay, so how to manage ventricular septal rupture in STEMI? There's two ways of handling this. First one is immediate medical management, where you have First is oxygenation lah. Make sure the oxygenation is well delivered to the patient. It can be an IV, non-invasive, or mechanical support with intubation. Number 2, inotropes, because you need to make sure the circulation of the patient is well perfused. Number 3, this is IABP, and for those who are not familiar with IABP is actually a device to help perfusion to the coronaries, whereby this is the balloon of the IABP. Okay, what the function is, whenever the heart is in a diastole movement, this balloon will be inflated, thus increasing the preload of the heart and infuse the blood through to the heart own coronaries. Okay, so this is what IABP done. And whenever the heart is in systole, the balloon will deflate and flows the blood through the peripheral circulations. Next, we have actually a lot of device for mechanical circulatory support, but these are ones of the most common used. Next is impeller. Impeller, its function is to suck the blood from the left ventricle straight to the perfusion, straight to the peripheries. It doesn't work like IABP, but straight away it gives, basically what it wants to do is rest the heart. Rest the heart so that the impeller takes the function of perfusing the blood to the peripheries. And last but not least, ECMO. ECMO stands for extracorporeal membrane oxygenation. It's a very hi-fi machine and very expensive. 1 day of ECMO costs you about 40 to 50,000 ringgit 1 day. Okay, so these are part of the mechanical circulatory support that is available here in Malaysia. Next is definitive management. So definitive management means by hook or by crook you have to do this, if not patient will die lah. So the definitive management for VSR is basically a surgical repair, and it can be divided into either emergency surgery or delayed surgery. For emergency surgery, patient, for example, our patient, it is falls under emergency surgery. Because if you don't do the surgery, patient will die, and this is what happened to him lah. And the next is delayed surgery, meaning minor or small rupture, the hemodynamics still okay, still can tahan, can delay a bit and pre-plan the surgery properly, then we do delayed surgery. Okay, I may not be the best person to talk about surgical repair because I'm not a surgeon, but this is just a picture that I got from the internet, and I'm just showing you guys. So I think I will do injustice if I explain further about this. So that's the title of our CPC today, when the wall breaks, which represents the myocardium of your heart. When the wall breaks, then the silent trembles. So usually the heart works in silence. You don't even realize that your heart works for you unless you got palpitation lah. But then when the wall breaks, this heart trembles and it will go chaotic and everyone will be on their edge. Thank you.
So based on that, now we are going to talk about VSR, ventricular septal rupture. So you've seen the case, you've seen how the uncle at the age of 74, okay, pay attention to the classic component because this is where the pattern recognition starts, all right? So we know now patient have got VSR, or ventricular septal rupture. We've learned that he's a 74-year-old gentleman who had chest pain for about a week or so. Okay, that itself is a risk factor. I'm going to tell you why. Chest pain, 74-year-old, who presented a week after the onset of disease. Okay, so based on that alone, what does it tell us? Is it early or late? There's a delayed presentation. The age factor is also a common denominator. So pay attention to this because these are pattern recognition so that when you're managing this patient in the future, you see some traits, some patterns, some risk factors, then it straight away reminds you of this session today. It reminds you of Dr. Haidir's very nice pictures and presentation. Okay? elderly man, delayed. And then we also saw the ECG changes. Okay, the ECG changes involve mainly ST elevation and Q wave in V2 all the way to V5, which suggests involving of the LAD or the anterior region. Okay, these are all the common risk factors that has been reported elsewhere, which Dr. Cheang will shed more light into that soon. But I'm going to quickly go through this with all of you because it's very important to realize that VSR is rare. How rare? It's even rare now than before, because before PCI era, okay, in the pre-thrombolytic era or pre-PCI era is more than 2%. That means in 100 patients with MI that you treat, more than 2 of them or 3 of them will get this complication. Now, with the PCR or angioplasty, we've seen less and less of that, less than 1%. That means in 100 MI that you guys are going to treat, maybe 1 or less that we're going to have this complication. Some studies have shown is 0.25%. That means you're treating 1,000 myocardial infarction patient, you probably see 2. Right? That's how rare it is now. But even though it's rare, doesn't mean it does not happen. So this is where we have to pick up early, because the diagnosis of VSR in itself is death sentence. 50% of patients, even though they've been treated, they will die anyway. So even they go for operation, the mortality is above 50%. If they go for conservative management, we decide not to do anything, it's invariably fatal. This is what happened to the uncle. Because of the cancer, because of the risk factor, family also do not want to risk patient further, then decide for conservative management, and he succumbed to death within 24 hours. So we have to learn that it's a catastrophic mechanical complication of acute MI. The incident is rare, but it's even rarer now. Mortality more than 50%, and it actually has a bimodal presentation. Based on the data, yes, if after 5 days they come with chest pain, in this uncle, 5 days, right? 1 week. So there's increased chance of having rupture wall or myocardial infarction with this complication. But there are also studies that have shown that it has a bimodal presentation. Within the first 24 hours, you can also get VSR. And then after 5 days. So bear in mind, VSR have got a bimodal presentation. Very early, within 24 hours, or very late. Now, this is the very important point for the medical student as well as to all the doctors, especially the residents. You're dealing with the first line. When you hear any murmur, in the new murmur, in the setting of MI, do not ignore. In general, any murmur in myocardial infarction, especially it's a new murmur, do not ignore. I repeat, it can be a sign of rupture. I'll give you an example. It could be an APO with a pansystolic murmur. If you have a right ventricular infarction or inferior MI for the resident in emergency medicine or medicine, if you have a new murmur in the inferior MI, think of papillary muscle rupture. But if you have a new murmur in the setting of anterior MI, think of ventricular septal rupture. Okay? If they have cardiogenic shock, but not much of a murmur, it could be a free wall rupture on the lateral side. So the ruptures in the MI can present in several ways. So I repeat, if they have a papillary muscle rupture, typically have inferior MI. So if they come to you with APO picture, with inferior MI, cardiogenic shock, pansystolic murmur, think of papillary muscle rupture. Second condition, they have anterior MI, they have pansystolic murmur, think of possible ventricular septal rupture. But if they have no murmur and yet they are showing some degree of rupture in the echo and whatnot, it could be a free wall rupture on the lateral side. All right? So in this case, ECG is very crucial because it can help you to re-stratify and make a diagnosis. Echo, bedside echo, very important as well to make a visual support of your diagnosis and to recognize that this is a prompt, urgent diagnostic and therapeutic action needed with your cardiology colleague as well as your cardiothoracic colleagues. Okay? And a bit of pathophysiology, Just now, Dr. Haidir has mentioned that when you have a rupture, you have a shunt that goes towards the opposite side. So you can imagine the heart on the left side is pumping the blood to the systemic system, and a big portion of your blood goes back to the right side. No, it gives pressure to the right side, but at the same time, it gives pressure to the left side as well. So this builds up the pressure in your left side, left atrium, and goes back to your lungs and gives rise to acute pulmonary edema. And at the same time, they have reduced output on the left side because 50% goes into the left side, not all goes towards the systemic system. Therefore, your kidney do not get the blood, the brain starts shutting down, and of course, the BP continues to be low, and eventually, patient will die. So, like I said, it's a catastrophic mechanical complication in myocardial infarction, although it's rare. So, in the last slide, I would like to call on Cheang to conclude the risk factors that you have to take home message from there before we conclude with Prof. Surya. This is what we can relate to what the patient had in our case.
Thank you, Dr. Azlan. Based on a numerous previous study, found out that we categorize the patient's risk factor into patient-related factors or infarct or lesion-related factors. As Dr. Azlan mentioned, highlight before, patients who those with presented older age are prone to get VSR. Why? It's because of the old myocardium are prone to get ruptured due to the less resilience. The second point, female sex. Why? Because it's female. They found that female usually presented to us with delayed presentation, or they came with atypical presentation, lethargy, hypoglycemia, and so on. And no prior ischemic heart disease or no prior MI is due to, they found out that due to lack of collateral circulation and prone to the VSR rupture. And hypertension is due to chronic stress on the artery. And smoke, they found that smoking as a part of the less significant risk factor. The second point, infarct or lesion-related factor, they found that which patient presented to us with first time and is a large transmural MI, particularly involve the anterior LAD because due to the septal perforation artery from the supply, the myocardium is from the LAD, and then those with single vessel disease, delay or absent reperfusion, and patient who underwent angiogram and found that there's a persistent total occlusion with a TIMI 04 on the angiography. So for that, I will proceed with the Q&A session. I would like to invite Prof. Surya to conduct the Q&A session. Okay, student can continue with the Menti-Menti just now.
Okay, your first question is, what new heart sound commonly heard in ventricular septal rupture? So excellent. Okay, and 100%. Okay, excellent. Yeah, true. So the harsh pansystolic murmur is caused basically by the turbulent blood flow because of the rupture of the blood from the left ventricle to the right ventricle. Excellent. Okay, next question. When does ventricular septal rupture usually happen? After a heart attack? Within few hours. Excellent. 100%. Okay, you guys have been listening very well to the presentation by Dr. Azlan, Dr. Haidir, and Dr. Cheang. Betul? It's 3 to 5 days after, because the muscle has now weakened, necrosis, so it's easily ruptured. Okay, next, last question. What is the definitive treatment for ventricular septal rupture after MI? Urgent surgical repair. Ni betul ke 100% ni? 46, 50 intra-aortic balloon pump. Okay, not really. Intra-aortic balloon pump is only to assist or support the patient, but not the definitive treatment for VSR. Urgent surgical repair is the treatment if the patient is stable and able to actually go for the surgical repair. Right, okay. I think our take-home message for today. Okay, I think it has been highlighted throughout the presentation. Yeah. So first of all, when you see a patient with new pansystolic murmur or even any murmur at all, in acute chest pain that you suspected myocardial infarct, you have to have high index of suspicion that this patient may have VSR or other mechanical complications like papillary rupture. Yeah. Okay. Second take-home message: the role of bedside echocardiography. I know that all of us will do ECG for a patient with acute chest pain. Very good. It cannot be omitted. You have to remember to do ECG, but also to highlight the importance of point of care transthoracic echo. In emergency department, not all ED will actually have TOE, yeah. Tapi patient pun tak stable to actually go for TOE, but transthoracic echo is actually very quick. It's bedside. It can be completed within 5 minutes or so, yeah, to actually confirm ventricular septal rupture. As you see in the presentation, you can have apical 4-chamber view, you can have sub-Zeeforth view to actually see whether the patient actually have ventricular septal rupture. Third point is actually to understand the pathophysiology. A patient with ventricular septal rupture will have left to right shunt. Yeah, so there's mixing of blood from the left ventricle to the right ventricle that will lead to reduce in cardiac output. Yeah, so the patient will have cardiogenic shock and unstable, most of them. Last but not least, and also the reason why the mortality is actually very high, more than 50%. So last key take-home message is rapid recognition. Yeah, so early identification of VSR will allow early management, the definitive treatment for surgical repair, and also to initiate supports for the patient, hence making the patient able to go for surgical repair. Okay, so very, very important. I think these are the 4 take-home message from us, from the Department of Emergency Medicine. So next time, if you see a patient with new murmur, suspected of MI, think of mechanical complications or VSR. I think with that, I would like to thank, other questions daripada Dr. Hamad to the students, I hope. Yes, please. Okay, please welcome Dr. Hamad. Okay.
I think it's a very good case sharing. Just a few points to add on. I think it's not that saying that this is a bombastic point. The decision for the surgery, I think at this acute setting, usually the surgeon will not go, and sometimes depend on the target area. So if you remember this angiogram, it's quite distal, the LAD there, from mid to distal, and if the surgeon go in, they will usually struggle to get at the distal target for grafting. So if they want to use the lima, left internal memory artery to that area, quite distal to find where is the target. So number one, the technical difficulty in this case. And number two is in the acute setting, usually the myocardium are quite frail, meaning that flabby. So if the surgeon want to patch that area that ruptured, the surgeon need time. Okay. So in our practice, usually what we do is we call natural selection. All right. So if we do angiogram and we do angioplasty at this case, usually we kill the patient immediately, because once we reperfuse the area of rupture, the myocardium, remnant of the myocardium that survive will make the contraction in that area stronger. That means that your area that ruptured become more unstable. That's why if we immediately PCI this patient, stenting this patient at the acute setting with the VSR, we kill the patient immediately. So what will happen is, usually we call it a natural selection. So we keep the area become stenosed. If there is a LED stenos at that area, let it be. Do not open, and wait for until 2 weeks. The area become more stable, and the surgeon usually go in at this time. So because the myocardium, the remaining myocardium become more stable, and the patient naturally selected to survive. Okay. Another advanced treatment, we call it implanter, occluder. So some of the area in Europe, they explore this. So while doing the PCI, the area that, if you see the video of the ASD repair or VSD repair in the pediatric cardiology video, the implanter that they use there, the occluder, so this one also been explored. But in the acute MI, the result is not so good because the occluder will not stay up because there is a lot of the area that not holding this occluder. So I think, yeah. So in this case, yeah, very high risk. One is complications occur, it's very high risk. And I think in terms of the recognition, I think you still have to go examine the patient. That's the key point. When you see the patient in the ED, don't be too smart and say, this is MI. So no, you have to examine and make sure that you heard the murmur. That will guide you into the next stage, which is if we have the bedside echo, which is I think we need the new machine. Okay, we need a new machine. Definitely new machine. Yeah, yeah. So I think as I highlight, has been highlighted already, it's a very good case discussion, and I think the team has done tremendously well. So that's I give it some of the additional things to for the education. Thank you very much. Yeah, thank you.
Thank you very much, Dr. Hamad, for the input. I think that gives you guys a clearer picture, yeah, regarding VSR. Okay, I think I would like to conclude our CPC for today. Thank you for all your involvement during the CPC. Okay, see you guys next week. Bye-bye.